Hi, so I'm Sherry Lee Smith. I'm here today with Anna Clarke. So, Anna, for our listeners that don't know you, would you mind giving us a bit of a brief introduction to explain who you are?
Yeah, so my name's Anna, as you said. I am an EMDR consultant. I'm also a play therapist and a psychologist. And I do a lot of work in the neurodiversity affirming space, sort of running education and trainings in that area.
Thanks for joining us, Anna. So I had a chat with Caroline last week about neurodiversity affirming practice and how that related to EMDR in particular. So for our audience that didn't catch that interview, are you able to give us a quick rundown of what neurodiversity affirming practice is?
Yeah, so when we're talking about neurodiversity, we're talking about a very broad spectrum of having, like where all of us have different ways of thinking and being in the world. And then we have people whose way of thinking and being falls into more of a minority population. So if they're autistic or ADHD, as just one example, there are fewer people who have what we call that neurotype or that type of brain in the world. But also within that neurodiversity spectrum, there are other types of brain differences that are included within that. And when we're talking about neurodiversity, the idea is that rather than thinking that there is one way of brains working. Essentially, it means that we're going, okay, well, rather than trying to correct people and all bring everyone up to the one way of thinking or behavioral communicating, we need to think about the fact that brains are always designed to work differently. It's why we have so much variation in the species and can actually survive as humans because we need different perspectives. So we're trying to move away from pathologizing those types of differences and more towards those approaches where we are putting supports and accommodations in place from a strengths-based perspective regardless of what type of brain you have or how you think, essentially.
So really trying to, I guess, modify our practice so that it can be optimal for whoever we're working with.
Yeah, yeah.
Yeah, so I wanted to talk to you in particular today about neurodiversity and parts work. So most therapists would be thinking of sort of IFS or schema modes, but what does it actually mean in practice to work in a neurodiversity affirming way when we're looking at parts work?
Yeah, so I think that we are, in the sense of parts, normalizing the idea that we all have parts because it's been typically really associated with, I guess, pathologizing it as being something that's wrong with a person in the sense of like that very diagnostic lens rather than, I guess, looking at it. I see that neurodiversity affirming practice is very often aligned with trauma informed practice. So, going rather than this being a very deficit based view, we're going, well, someone might have developed parts that are more distinct and maybe have more of that dissociative layer in response to trauma and other things that have happened there. So there are lots of different ways about thinking with parts from an affirming perspective. And I think it's a very new conversation to include talking about parts within that. I know that there are like differing perspectives of it coming out because there are the fact that if someone has quite distinct parts, there's often a lot of trauma that's occurred. So it's not that we want to celebrate or normalize all of the terrible things that have happened to cause someone's brain to decide that it needs to split into very distinct pieces in order to stay safe. But it's looking at that through more of that trauma informed, strengths based, non pathologized lens about there not being something inherently wrong with that person, but that it makes sense in the context of the environment and everything else, regardless of how dissociative someone is or not.
Yeah, and so why do you think this conversation is particularly important at this time, given the kind of wider context of what's going on with social change in our industry?
Because with parts work, and I'm going to talk specifically about having complex dissociation, it's a very, very highly stigmatized thing. And especially if we're talking about something like dissociative identity disorder, there's lots of different assumptions based on very horrible depictions in movies, TV shows, lots of cliches about serial killers. Like, I don't know, because people can't write a better script than that or have a better twist at the end than that. It's a pretty, I don't know, I think you need to work a bit harder now to come up with an interesting plot line. But that has done so much damage to people who have those experiences. So there is a need to, and that's why people don't disclose it, and because they think that people won't think they're fit to do their job or whatever it is. And it has often been like quite a dirty word or something that has, yeah, been like there's really something wrong with me. So I think it's important for people to break the stigma so that people can come forward and get help, so that therapists don't fear working with it either. Like there's a has often, I think, been very much a like not touching that. But if you're working with trauma survivors, you're working with a level of dissociation and probably more distinct parts. So it's really important that people are more familiar with and building their comfort in ways to work there.
Yeah, and I guess as that changes in our industry, there's probably going to be more clients that are disclosing that sort of thing. So when that does start to happen more, what sort of ways might traditional parts work interventions fall flat when we're working with neurodivergent clients?
Yep. And so I think just to define that, like if we're talking about that word neurodivergent, like we are speaking about a very broad range of brain differences, but I think it's often very commonly associated with autism and ADHD, and that's my main area. So I can speak to, yeah, working with neurodivergent clients who are autistic or ADHD. I think it's really relevant because I have written recently like some research and that around and for dissociation and neuro and autistic people in particular. And we know that autism, people who are autistic are more likely to and ADHD are more likely to experience complex trauma and have lots of different things occur. But we also know that people who experience complex trauma are more likely to dissociate. So it's a very overlooked topic to go, well, you've got a group of people who's actually much more likely to experience trauma and therefore have the impacts of that. So we need to discuss how therapy approaches can account for that and work holistically with that in there too.
Yeah, and what sort of risks or missed opportunities might there be if clinicians aren't adapting their approaches to this sort of client group?
I think there's the risk of overlooking part of the problem. I am really focused on the integration of neurodiversity and trauma-informed practice. It's a lot of the education that I do. So we often the reason I really got into this space was because when I first started learning about this and speaking to colleagues, neurodiversity affirming practice and trauma informed practice I found was very much siloed. So it's like people knew one and not the other, but like it just, you have to put them together essentially. So, and I think it's really come a long way in the last 5 years since I first started working in that space, which is awesome. But there is still the risk of seeing everything through like an autistic or ADHD lens, or everything is being explained by trauma as well. So whereas there can be so much overlap between things. To give one example, for ADHD, there can be confusion there about dissociative symptoms, like on a questionnaire or something like that. It might be about someone vaguing out or forgetting where they're going or leaving things lying around. Well, without proper teasing that apart, which one is it? It could definitely be both. But I think it runs the risk of misdiagnosis, also like not coming at it therapeutically with the right strategy. So if you think that someone's dissociating, you're going to use maybe some grounding strategies or other things there to try and help the person be more present, and then not forget and lose all their things. But if they're ADHD, you might teach that till the end of time, but it's only like a stimulant medication or whatever it is that's actually going to help the problem. So it's kind of like you're throwing out very, very well-intentioned strategies, not necessarily doing harm, but it's not being as effective as it could be.
So I guess it really highlights how important it is to integrate these two kind of areas of knowledge, yeah.
Yeah, definitely. Like you can't really have one without the other in my book, because if you're working with autistic and ADHD people, they're more likely to experience trauma. So if you're familiar working in that space, you need the trauma informed angle. But if you're already trauma informed, but you can't identify autism and ADHD, they're the clients that whether you know it or not, you're going to be working with autistic or ADHD clients because they might be coming in under other diagnostic labels, or and that, like, we know that there's a huge overrepresentation of autistic and ADHD people within clinical settings. So I guess the irony is, like, both settings are actually working with both, but the way that we've looked at treatment for so long has been so boxed, essentially, or siloed, like that word I used before.
Yeah. So how might neurodivergent clients experience parts work differently than neurotypical clients?
I think there's lots of different ways. So if I maybe, and I think one of the things we need to think about is that every person is different, whether they're neurotypical, neurodivergent, and that. So there might be themes, or there might be different patterns that are more common for an autistic or ADHD client, but some people might not need adaptations at all, just like the same with any client that you work with. So it's not like a prescripted way of having to do it with autism or ADHD, but there's different considerations you might take into account. So I think, like, if I start from an autistic lens, one of the things might be that the concept of parts might be quite abstract. So the like it's with literal interpretation of language, and it's like, well, parts don't exist. Like they're just you're making them up. It's not something tangible or real, for example. So understanding the purpose of what we're doing and why. There might be challenges with visualizing different parts or using some of the imagery exercises that we might traditionally do. Those are just a couple of examples. ADHD, it could be that it's hard to even attend long enough to the psychoeducation about parts, because it's just like you can't focus for that long on psychoeducation about parts, which can be quite long sometimes to really explain the concept. Or there might be things as well, like even if we think about positives around people who are quite creative, or like whose brain's tangential, that might make different connections between different parts or be particularly good at visualizing. So there's ways that you can actually lean into that, and that strengths-based approach there too.
So I was just reflecting on the fact that you were talking about, potentially neurodivergent clients having trouble with things like imagery or metaphors when working with parts. What other sorts of challenges might you come across working with this with neurodivergent clients?
So with like imagery components, like people can have aphantasia, which is where it's like visual imagery is a spectrum, mental imagery, sorry, is a spectrum, from people who have aphantasia, who don't visualize in or mentalize in pictures, it might be in words, all the other way up to hyperphantasia. And there's 1 to 3% of people who sit at either end of that scale. And then there's all the diversity in the middle and people who cluster around the norm. But at the hyperphantasia level, it's that imagery can be so vivid, it can be hard for people to differentiate, like really getting sucked into it and seeing every little detail, which can be fantastic for imagery-based exercises or calm places or whatever it is. But it's a literal nightmare for PTSD symptoms, because the vividness of flashbacks and nightmares is very reliving all of the time. Some people, on conversely, who have aphantasia, the absence of mental imagery means that sometimes there can be really big feelings or triggers in the body, but like can't pinpoint it on a memory that's coming in. So it can be like someone's really distressed and they don't know why because they don't have that thing to pin it on. It's just like my body's really anxious. So there can be challenges either way, but aphantasia does protect against the visual intrusions with PTSD, which I think is really, really interesting. So that's a little bit of a tangent, but I am really interested in that area. But so if we're thinking about parts work, like we can, if people are, they don't have to be at either end, they can be in the middle. But if they have a tendency to really enjoy imagery or that there might be lots of different ways to use that. Conversely, if people struggle with imagery and we're trying to do imagery-based exercises, it might be that we need to focus less on asking them to picture it and more use words like describe it, tell me about it. So do a descriptive explanation that's more using words, or it could be having things tangible. So, I will normally just pick up whatever I've got on the table unless people have their own things to do, but it might be, okay, imagine that like this part of you saying this and this part of you saying that. So kind of externalizing it on something to look at rather than a visual, a mental visual that doesn't exist. They're just some
Yeah.
simple things.
Yes, I guess it's about opening up, or giving ourselves permission to be a little bit creative
Mhm.
with this work. So I'm curious, how do we sort of help clinicians balance that structure and flexibility when we're using parts work in a neurodiversity affirming way?
Well, I think that like parts work, all therapeutic modalities are taught in a certain way. And when we're first trying to get our head around it as therapists, like we follow scripts or things like that. And it's kind of, it's hard to ad lib and I'm not necessarily thinking we should, right? Especially, while we're getting our heads around a new approach, we want to go with what we've been trained in and know, especially because we've got our training wheels on and our executive functioning's more overwhelmed, right? Like you're trying to remember how to do the thing and then how to adapt it. And it takes a while to build your comfort. So I think it can be then maybe with particular clients who you're feeling more confident with or who you feel like are more resourced, maybe trying some adaptations there to just sort of build your comfort with trying something a little bit different and then going, okay, I'm not sure how to do this with this client. I might take that to supervision or consultation. But it's, I think there's conversations to be had about how people perceive like trying something new in therapy. Like there can be something where it's like, oh, I feel like I'm going rogue or whatever, but going like, is this actually doing harm to someone? Like if I'm asking someone to like look at two balls and go this part versus pointing, chair work, pointing to this chair or that chair when that's not working for someone, or visualize it. It's all actually the same thing. So I think, one of the things like I will say is like, if we think about EMDR, if someone's blind, you're not going to use eye movements because it's literally not going to work. You're going to use butterfly hugs or things. So, but we know it's still effective and works. So sometimes we have to come back to, I guess, going like the point rather than getting lost on the details and going, yeah, I'm not suggesting some wacky, wild thing that's got not related at all. But I think if we can compare things sometimes to physical differences of like, I'm not going to ask someone to use a strategy of going for a run if they've only got one leg. I'm not going to ask someone to visualize if they can't. I'm not going to ask someone to use a metaphor they're not understanding. I'm going to try and adapt.
Yeah. So in that regard, what do you think would be the most important mind shifts for therapists to have around this work?
I think, that's a good question. I would say being client led in the sense of letting them tell you how things land, like whether it makes sense or not, and going, can I explain it a different way? Or maybe this component of the theory works for this person, but this thing doesn't seem like it feels as relevant to them. So it can be going like, which parts of things do I adapt or drop? Or I sort of try and think of being a therapist is like I've got a big toolkit and I've got EMDR in there, I've got some schema things in there, I've got my play therapy training, I've got my family violence training. Like all of us bring very different backgrounds into that toolkit. And rather than going like I'm doing EMDR with you, I'm doing play therapy with you, I'm doing CBT with you, I'm trying to just pick different things out of the toolkit for that client rather than going, I'm going to siphon off this part of the toolkit for you or this part for you. So thinking in that like, oh, there's this like random thing I learned in a training 5 years ago I've never used before. Like I can think of some particular cases where, I don't know, there was like an EMDR training and someone did something like a little bit differently in how they did it. And I've never used it, but it's suddenly like, oh, this client, like, I remember that thing that I've never had to use an adaptation like this before, but suddenly it's relevant. So it's kind of, yeah, looking at what's our sort of knowledge base altogether sometimes rather than specifically, I'm doing this therapy now and this therapy now. It's more integrative.
Yeah, so I guess it's really being quite flexible with your approach and then taking a collaborative approach with the client to
Yeah.
work out what's going to best meet their needs.
Yep. And we don't need to know
Yeah.
like every type of therapy or thing or all of that. We can all upskill or learn different stuff as well, but there's things that I'm going to be like, I'm really bad at teaching people mindfulness exercises. I'm not great at doing a meditation script because I pace it too quickly or whatever, and I know that about myself, so I try and like outsource. It's still, I know that those sort of resources and that is still really important, so I don't just like dismiss it, but I might outsource that to sort of a different way that the client can get that and go, I'm better at parts work or that, but I know that some of those other things I could try and be perfect at it, but it's just not the best that I can do in that case. So I think knowing, yeah, that we can offer enough with what we know and going, yep, we can upskill and learn different things. But I think sometimes there can be a bit of pressure to want to do therapeutic gymnastics or whatever to go, I need like a specific technique for this thing rather than zooming out and going, there's a human being here. So how do I listen to what they're needing?
Yeah, so I guess it's the therapist using their own strengths
Mm.
to bring to what the client needs as well.
Yeah, definitely. Yeah.
Yeah. So is there any sort of golden principles that you would consider would be something to keep in mind for therapists working in this area?
I mean, I think it's that being client-led component, and I think being generally aware of the overlap with neurodiversity and trauma. So really getting some knowledge there so that you can feel more confident in differentiating dissociation or trauma symptoms versus autism and ADHD, because then you are going to know, okay, what type of thing do I need to pull out of the toolkit? And am I putting some neurodiversity affirming environmental support strategies in place? Or am I using some parts-based intervention? Or am I doing the parts-based intervention, but with a bit of a communication adaptation on it because someone's really literal? So I would say that one of the key principles with this population is building confidence in some of that differentiation of what's going on.
Yeah, so I guess the more knowledge that people have in the sorts of presentations that might come through might help them be more strategic about which sort of
Yeah.
interventions they're going to use.
Yeah.
Yeah. So you've highlighted some really powerful strategies today. It's a lot of stuff that we're not taught in our basic training. So I'm curious as to what you think or why you think this gap exists in our current, you know, training modalities.
Because the research with autism and ADHD is the most rapidly moving in psychology, and we've got increased diagnostic rates around women, gender diverse people, people from different cultural backgrounds, and the like, particularly over the last 5 years. So there's been this sort of sudden. Like people have been screaming about it for a long time, but there's been this sudden realization and uptake from a lot of people going, oh gosh, like I'm actually already working with autistic and ADHD clients and I need to adapt. But there's what we have, the research to practice gap, where our research is now going, yep, autistic and ADHD people experience a lot more trauma, but that then takes time to filter down into practice or to go into like it's actually probably more known on the ground at the moment, but then to get that accredited and put through a university with going, yes, this is what we know now, and changing a curriculum can take years. So then you have therapists who are coming out of training programs who haven't been taught about it, and then they need to go seek their own extra professional development, and kind of it's like an opt-in approach to earn, like it's not really as much anymore with the new APRA competencies if you're a psychologist, for example, about neurodiversity affirming practice. But that's kind of what's been going on, is that it just hasn't been something that's been taught because people haven't known about it. But now there's this catch-up period going on.
Yeah,
I
so
hope
you're
it'll change.
yeah, so you're offering training for therapists to go a little bit more deeper into this. Can you tell us a little bit about how your training helps clinicians to put some of this stuff into practice?
Yeah, so Carolyn Burrows and I are really excited to be offering a webinar on parts work and neurodiversity, like particularly autism and ADHD. So the things that we'll be covering include that overlap, and really trying to, because people will be becoming, I think, a bit more familiar with trauma, autism, and ADHD overlap, but going in more specifically to sort of dissociation as well. So teasing that layer apart a little bit. We need to think a little bit about if we're thinking about parts work generally, regardless of, dissociation and other things there. I think one of the important things to consider is the types of parts that autistic or ADHD people might have. So there can be a part that's particularly good at masking. So like a part that's really designed in that person's system of parts to pretend to be neurotypical. So I think there's some things there to be able to work in a way with those parts so that there's the understanding of why, like what that role is, why that part formed, to be able to, yeah, explore what's helpful from there. So taking what we know about working with parts and putting it through the framework of what we know about autism and ADHD now, how we adapt parts work when there's, different things like aphantasia, communication differences, distractedness, other things that come up when we're working with this population. And yeah, some general, I'm really excited to be sharing some different creative ways of engaging with that too.
Yeah, I don't think I've seen a training yet that has brought all of that together in the way that you guys are bringing that together.
Yeah, really excited
Yeah.
it's nice to do some different topics, and especially to do sort of with Carolyn as well to, yeah, I guess bring together two different brains on and perspectives of that, because we all do work with clients a little bit differently and bring our own backgrounds and lenses. So I'm really value collaborating with people to go, oh yeah, I don't do it like that. I often learn when I'm facilitating with other people as well.
Yeah. So what sort of clinicians is this training really geared to or suitable for, and what can they expect when they're done with your training?
So I would say it's for, like, if people are already doing parts work and have some familiarity with that language, and that it's going to be an extra layer to add on to what you're doing with that work. For people who are less familiar with working with parts, I guess it will provide like an overview of that language and what it is and how to start thinking about it. But it's definitely something you'd need to do a much more deeper dive into beyond that surface level. But it's something that if you are working with neurodivergent people and sort of start noticing those things to do with parts, at least it'll give you a baseline understanding and awareness of that, versus people who are already quite confident working with parts. It's okay, well then how do we go and adapt that for this population?
Yeah. So you also offer some other training programs and consultation services. If people are interested in finding out about that, where can they get more information about that from?
So I run a training company called Divergent Futures, and I do a full day neurodiversity affirming EMDR therapy workshop where we talk about adaptations in that space. We also, so my colleague Monique Mitchelson and I, we also do webinars and trainings on particular topics. Like I think she's got some coming up on autism, ADHD, and premenstrual dysphoric disorder, as well as one on autism, ADHD, and sleep or chronic illness and burnout. So there's kind of smaller topics, as well as also if people really want to do that full comprehensive understanding of autism, ADHD, and trauma, and then very practical strategies on how to adapt therapy. We offer like some full day trainings on that kind of thing too in a we've got a tool that can really help with case formulation and like very practical guidance for some immediate strategies to get in and be using. Yeah.
So a lot there if people wanting to take a deep dive into this area.
Yeah, just different things that yeah, are of interest. And I think our brains take us on a bit of a deep dive down sometimes. So I also sometimes do some play therapy based things and the like too. Yeah.
Okay, well, thank you very much for joining me today. It's been lovely talking to you and hearing all about the new training packages that you've got and how you're sort of bringing all these skills to our industry. So thank you very much.
No, thank you for having me.